Alright, so part 3, the last part of my OR talk. I'm going to talk about portable OR films that you might see in our clinical site. Cross-table spines are probably our most common spines, our lumbar and cervical that you'll see. I've never done a thoracic, I think that'd be rare. KUB we usually do for an instrument count situation. If they have either over or under counted the amount of instruments used, we will do a KUB to make sure it's not in the patient. Pelvis can be either intraoperative, which is during the surgery, or postoperative after the surgery. Chest x-rays we usually do post-op if they have had an ORIF of the ribs, or in PACU if after surgery they're concerned about the patient or they just need to check on something, we'll do it there. Part of your program is to include a portable orthopedic competency. So just some examples of things that you could do. You could do a cross-table spine in the OR. You could do a portable pelvis post-op in the OR. Intra-op doesn't count. Portable pelvis in the trauma room. You could do a portable pelvis or a femur in one of our ICUs, so SICU or MICU. Portable post-op knee are done in the OR as well. It's really similar to AP and cross-table in the ER. A portable extremity in the trauma room or in the OR. Usually just severe cases. So they went, right from the trauma room to the OR and they need, an extremity that wasn't done or an extremity in the trauma room. It could be a possible amputation or something like that. That would count. We don't take, say, portable hand on a patient who can sit up and they can move their hand. That's not something we count as a portable orthopedic comp. Intraoperative pelvis is not a comp because the surgeon places the cassette for you, so we don't count that. All right. Cross-table spines most often are just a lateral. We used to have a surgeon that did AP or PA of the lumbar spine as well. But we don't really see those that often. So with you're going to use your Shimatsu portable, and they usually do a shoot through just to look at their level. So you can see where this little marker is. They'll have a metal piece sticking out of the patient to count their level, and they want to make sure they can have this sacrum on to be able to count. The skull has to be on the cervical so they can make sure and count and know where they're at. Okay. Portable spines. So when you're in the OR and you're looking at your schedule, and they will make a little sort of asterisk on the cases that have C-arms or not. If it doesn't have a C-arm and it's a spine case, that means that they want a shoot-through lateral at some point. I always look at my schedule first and say, what level are they working at? What do I need to see if they're looking at L2 or L3 or C4 or C5? Where do I put my cassette? Where do I center? Where do I need my light field to be? Depending on your case, your patient will be supine or prone. So that'll come into play either ACDF or, the posterior lumbar. Are they going to be supine or prone, and how does that affect my centering? When you bring the portable machine, you're going to park perpendicular to the OR table. Park close enough where you can swing out your tube and be able to center. So if you park too close to the spine, then you're going to have to move your portable. So be aware of that. And remember, the arm extends out pretty far. Okay. Take your portable cassette around to the other side. Make sure you have the correct grid on it. Make sure you're using the digital grid. Be aware of the sterile field. So face all of the sterile tables and watch your scrub jacket. Make sure it's buttoned before you go in. Walk all the way around, find the grid holder, put the cassette in the right way, make sure it's facing the correct way, and then you're going to wait. The scrub tech is going to drape your cassette, and the surgeon's going to clear the area, as well as the scrub tech, so you don't possibly touch them when you move in. You're going to move that cassette holder up flush to the table, push up against, watch for any tilt that could cause your grid lines. Hopefully you have a partner with you. It goes way faster if you have someone with you doing these portable spine cases, and you guys as students will have a tech with you. I always ask them to look for the shadow of the metal marker that the surgeon has placed, and that's how I sort of determine my height going up and down. Do I need to come up a little bit? So you want to be able to see that marker. Lumbar spines, bottom of the film at the patient's butt. Cervical spines, I put the bottom of my film just past the shoulders. And the scrub techs and surgeons, they're pretty good about showing me where the shoulders are, or I'll ask anesthesia if they can show me where the shoulder is. They reach underneath the sterile drape, show me where it is. Watch when you're swinging your portable arm out. Make sure there's no angle on your collimator. Set your technique based on the patient's weight, and then ask the anesthesiologist to hold respirations. You don't want them breathing and that causing motion. You're going to announce x-ray just like we always do for portables. Make sure everyone's clear. They don't often wear lead for these cases because they don't use x-ray for a majority of the case, just for this one shoot through. So anesthesia is probably going to run out the door. The surgeon may stand behind that clear rolling lead shield. Someone may stand behind you if you have a lead on. So just be aware of that. Missing instruments. Most often you're doing an abdomen film. And at our facility, we require the film to demonstrate skin to skin. So this image on the left here would not be acceptable because it's collimating off the side, the lateral borders of the abdomen. So we need to go, if you have to go crosswise, you have to go crosswise. If you have to do quadrants, you do quadrants. But you include skin to skin, making sure there's no instruments left behind, sponges left in the patient, anything like that. Hip replacement, pelvis. So for the hip surgeries, they do a pelvis view. And most often we're doing one intraoperatively and then post-op. Your film, you're not going to do a pelvis like I've taught you to do pelvis. You're not going to have the upper border of your cassette above the iliac crest. You need to center down lower. You're going to use more of a femur technique, right? Because you're penetrating here. This is your central part of your beam. They want to see the joint space, how it's sitting within the acetabulum, and you have to include past the tip of the prosthetic. You have to show this part of the femur underneath, and you have to see both sides. So if you're not low enough, if you're clipping this off, they're going to make you go lower. Right? Remember flail chests that we talked about a while ago? If they break a certain amount of ribs, then they're going to have surgery. So they're going to have to do some plates and screws for the ribs. Usually we do a chest x-ray portably, either in the room or in PACU once they're there, to show them the ribs and show if there's any pneumothorax hanging out. Sterile bags, cassette holders, sterile drapes. At our facility, we don't have this clear bag like she's demonstrating here. Most of the time, we just put our cassette in this type of holder, and then they put a sterile drape over the top. But I'm not sure if any of the other sites, you might see this clear bag, but we don't have that. But just make sure your bag is always covered, or make sure your cassette is always covered with a bag, right? Because we just don't want any fluids getting in that cassette. Some OR tips and tricks. Keep track of your OR schedule. Look at what cases are available. Make sure you're tracking what you've seen, what you need to see. Don't spend your entire rotation in daily. Make sure you see endoscopy and chestnut. Your technologists won't know what you've seen, so it's not their job to send you to those other locations. You need to decide and maybe talk to the fellow student that you're with. Hey, have you seen ERCPs? No? Okay. You go today. I'm going Wednesday. And, we'll decide from there, something like that. So make your plan. There's a cysto at 1 o'clock. You haven't seen a cysto yet. I'm going to Chestnut at 1 o'clock. I haven't seen a cysto, right? You have to run that. Notebooks. I know I've stressed this a million times, but always have your notebook. Keep track, make notes, have scratch pad with you, something. The markers, when you're marking the C-arms, remember that marker goes just inside the screw on the image intensifier. And anatomy, you're always going to mark the lateral border, just like we do, right, for any extremity work. Anytime I'm doing a C-arm case, I always push my C-arm, that in-out controller. I always have my C-arm halfway out when I pull in. it's a little bit easier for me. That way, if I have to move a little forward or a little back, it's a small movement and I'm not pulling the entire C-arm. I'm a big fan. I bring a note card with me. I write down the angles. I write down height, in-out numbers, stuff like that. Anything that can help me hit that AP or hit that lateral again the first try, I like to do that. Set your R's. So remember, if the patient is supine, if they're prone, if they're flipped, and it's all about that smiley face, and I'll go over that in a second. Listen to the surgeon for instructions. Watch their eyes. I always watch their eyes. If they're not looking at my monitor, I'm not fluoroing. Review your medical terminology. They may tell you to go distal, proximal, superior, inferior. You have to know those. Anytime you're going from AP to a lateral, swap the image first. They say go lateral. Swap the image, then go lateral. They say go back to AP. Swap the image, go back to AP, because you're going to forget to swap it, and they need to keep track of that image when they go to the next one. Any downtime in the OR, take advantage of it. Practice with the locks. Set up the C-arm in a room. Review your cases. Jump in with another tech. Always be looking at that schedule. When you come out from a case, if nothing's happened, look at that schedule and say, oh, Deb is in room 9. No, there's no student with her. I'm going to hop in with her there. Keep moving. See everything that you can see. Keep track of the cases. Write it down in your binder. Know what you need to know. Okay. And this was just a reminder about how to use those R's, right? So that's your annotation. So remember, it's by the smiley face. And if they're supine, they're smiling at the smiley face. You don't need any of these buttons. But always set this up prior to, and that way your patient appears in anatomical position when you make the exposure, right? So if the patient is supine, they're smiling at the smiley face, you're golden. You don't need to flip any R's. That patient's now flipped prone, but their head is still under the smiley face. The only thing that's changed is the right and lefts are swapped, so we do this backwards R. This patient is now prone, but their feet are under the smiley face. Their right and lefts are still on the same side, but they're just upside down, so you just need the upside down R. And then when they're supine, with head over here and feet under the smiley, you need both R's. All right, so you're going to do a lot of that. Just pretend to lay yourself underneath that image intensifier and imagine yourself being in the position and what's changed, what's different, what R do I need to hit to get my image to come up correctly. And if you don't get it right the first try, they'll just tell you, be like, hey, flop that, all right? Dave is a big fan of Franklin Roosevelt. He loves this quote. The only thing we have to fear is fear itself. Everyone tends to be a little bit nervous about OR, but if you know the case, if you know your C-arm and your C-arm locks, and you can sort of go with the flow and pay attention to the surgeon, you will be absolutely fine. Everyone makes OR into this sort of bigger deal than it is, and you're there to help that surgeon. You're there to be their eyes and do what they need you to do. So don't worry about anything else going on. If you can just focus on your task and what they're asking you to do anatomy-wise and get them what they need to know, you will be totally fine in the OR. Notebooks, notebooks, notebooks. That'll help you sort of maintain your knowledge, retain your knowledge. Always review that notebook prior to going to the OR. So the night before you're going in, review your cases and keep that notebook with you. Always have a pen. I also would love everyone to eat something in the morning. My students who don't eat something in the morning, that's when they tend to pass out. So please eat before you go to the OR and have fun. All right, so that rounds out part 3 of my OR talk.